Assalamu alaikum. Before I begin, I would like to start with a quick question, especially for our junior colleagues and trainees. And my question is, how many of you have observed or performed antegrade cerebral perfusion, deep hypothermia circulatory arrest, particularly in infants? Please raise your hands. No one? One hands up. As expected. Because these are very rare and complex procedures. So no hands up, no problem. It's understandable. Let's move on to our main topic. Today I will be discussing about the key perfusion related challenges and critical consideration in infant aortic arch reconstruction. Infant aortic arch reconstruction stands as one of the greatest challenges in congenital cardiac surgery, which demanding meticulous surgical and perfusion management to support fragile physiology. According to the available recent data, the mortality rate is 4.8%. These are main common indications why infant required aortic arch reconstruction: coarctation with arch hypoplasia, interrupted aortic arch, and hypoplastic aortic arch. These are key perfusion related challenges: limited blood volume due to patient size, controlled fluid management, minimizing hemodilution to optimize oxygen delivery, blood flow regulation, immature organ systems, optimal cerebral and systemic perfusion, deep hypothermia circulatory arrest, selective antegrade cerebral perfusion, conventional ultrafiltration management, and modified ultrafiltration. Let's move on to practical approaches where every decision can make a critical difference. Comprehensive assessment में क्या आएगा? पेशेंट की हाइट, वेट, लैब्स, कार्डियोलॉजी, एनाटॉमी, हिस्ट्री, ईच एंड एवरीथिंग. ब्लड फ्लो कैलकुलेशन आगे हम डिस्कस करेंगे आने वाली स्लाइड्स में कि कैसे हम ब्लड फ्लो कैलकुलेट करेंगे. न्यूबॉर्न का, इन्फेंट का, 3 kg का, 4 kg का. Selection of the extracorporeal circuit according to the patient's weight and the oxygenator according to the patient's blood flow. Optimized priming strategy, also a very important part of the perfusion. How we prime, what kind of solutions, crystallite, colloid, blood products we will add into the prime for infant, and how we calculate the desired and predicted hematocrit level before initiating bypass, and also maintain optimal perfusion markers during bypass. This is a blood flow calculation chart according to the patient weight, and here we can see the weight of 5 kg or below. We will calculate blood flow with cardiac index of 3.2 liter. For 5 to 15 kg, 2.8 to 3 liter. For 15 to 25 kg, 2.6 to 2.8. For 25 to 35 kg, cardiac index 2.4 to 2.6. How we select the extracorporeal circuit? Again, according to the patient's weight. For 5 kg or below, the pump tube size should be 1/4 inch, arterial line 316, venous 1/4 inch. For 6 to 10 kg, 1/4, 1/4, 1/4. For 11 to 25 kg, 3/8, 1/4, 3/8. And 26 to 40 kg, 3/8, 3/8, 3/8. Prime strategy is a very important part, as I said earlier. What kind of colloid we can add? FFPs, albumin. We can use fresh PACVTS, whole blood. Why use fresh? Anyone? Yes, please. Very good. Yes, yes, very good. And the one more thing, good answer. One more thing, the blood lactate level is also high with old PACVTS or old blood. So what we will do for overcome these things? Normothermic temperature, pre-bypass ultrafiltration, very important part. Pre-bypass ultrafiltration will reduce the potassium level, the lactate level also, and pre-bypass blood gases. तो हमें पहले से ही आइडिया हो जाएगा कि हमारे बाईपास प्राइमिंग के अंदर ब्लड लैक्टेट लेवल क्या है, पोटाशियम लेवल क्या है, तो हमें ब्लड गैसेस करवा के ये सारा आइडिया हो जाएगा पहले से बिफोर इनिशिएटिंग बाईपास. And the minimizing of length of extracorporeal circuit as much as you can. This is the volume calculation for predicted and desired hematocrit. तो हमें कैसे पता चलेगा अगर हम प्राइम कर रहे हैं, तो हमें कैसे पता चलेगा कि जब हम बाईपास इनिशिएट करेंगे तो हमारा हेमेटोक्राइट लेवल क्या होगा? हेमेटोक्राइट level is a very important part of perfusion. Why? The hematocrit is main source of carrying oxygen for perfusion. So how we calculate the predicted hematocrit level before initiating bypass? Here is a formula. 85 multiplied by 8, 8 is the patient weight, and we get the patient volume 680 ml. 680 plus 500 is prime volume, and we get the answer of total volume of on bypass of this patient, and 0.35 is the current hematocrit level of this patient, 35%. So now the patient volume multiplied by current hematocrit, and we get the answer, and the answer divided by total volume on bypass, and we get the answer of predicted hematocrit 20.1% when we initiating the bypass. So we get answer before bypass what will be our hematocrit level when we get first ABG. Understand? Another calculation for desired hematocrit, or what hematocrit level we want to achieve when we initiating bypass. Patient volume again multiply with current hematocrit level, and total volume on bypass multiply by the hematocrit which we want to achieve when we initiating bypass, 28%. And the answer minus then 92.4 divided by 0.70. What is 0.70? This is constant value. The value of 1 pack RBC's hematocrit is 70%. So 132 ml of pack RBCs we must add into our prime volume to achieve a desired hematocrit level of 28%. So we get before bypass. All this kind of strategy is also very important to better outcome. Any question? Deep hypothermia circulatory arrest is a safe and useful technique for protection of the brain and other vital organ. It is used during major aortic and other cerebrovascular surgeries. The temperature range of deep hypothermia circ arrest is 18 to 28 degree, and the maximum safe circ arrest time is 45 minutes. Selective antegrade cerebral perfusion we mostly use in infant aortic arch reconstruction. Selective antegrade cerebral perfusion maintains cerebral oxygenation with hypothermic blood, which optimizing neuroprotection and minimizing the ischemic and cognitive injuries of the brain. Selective antegrade cerebral perfusion, blood flow range is 30 to 50 ml per kg per minute, and the pressure should be maintained between 30 to 50 mmHg. Here we can see the diagram of the aorta. Ascending aorta, aortic arch, and descending aorta, and few arteries arising from the aortic arch. So normally we are inserting the aortic cannula into the aortic arch, right? Here, this point. When we start to cut aortic arch for reconstruction and for initiating the deep hypothermia circulatory arrest and then antegrade cerebral perfusion, selective antegrade cerebral perfusion, then we turn this cannula from descending aorta towards the ascending aorta, and we snug these two arteries, left subclavian, left common carotid arteries. Why snug? Why we clamp these two arteries? To avoid embolism to brain. Then we start the selective antegrade cerebral perfusion. Usually we are using this cannula, aortic cannula. You can see the tip. This tip should be turned from descending to the ascending when we start selective antegrade cerebral perfusion. Hope you guys understand. Here we can see the optimal perfusion markers during bypass. Flows should be maintained between 2.8 to 3.2 liter per minute per square meter of cardiac index. Hematocrit level 28 to 30%. Mean arterial pressures 45 to 55%. PO2 250 to 350. PCO2 35 to 45. Mixed venous saturation 65 to 75%, ACT above 480 seconds, and lactate level 0.9 to 1.7 millimole per liter, and urine output 1 ml per kg per hour. Now I would like to share one of the case experience. The patients came to AKUH, age was 3 months, baby boy, with weight of 3.8 kg, height 62 centimeters. With interrupted aortic arch, dual SVCs, double outlet right ventricle with membranous VSD and PDA. Huddle briefing and plan was discussed within the team. Usually we are discussing surgical anesthesia and perfusion team before surgery. Extracorporeal circuit 14316 was assembled with oxygenator of baby FX5 thermo and primed with fresh whole blood and albumin. The cardiac index taken 3.2 liter per minute per square meter. After initiating the bypass, del nido cardioplegia was utilized for arresting the heart. Aortic cannula, as I shared earlier, 2.6 mm, and 2 venous cannulas was inserted into the SVCs, 114 FR for IVC. Aortic root 4 FR was used for cardioplegia delivery, and mean arterial pressure was maintained between 40 to 55, mixed venous 65 to 75%, hematocrit 28 to 30%. Conventional ultrafiltration was done according to the fluid management. Deep hypothermia circulatory arrest was initiated at 20 degree. Selective antegrade cerebral perfusion pressures flow maintained at 40 ml per kg per minute, and the selective antegrade cerebral perfusion pressures were maintained between 30 to 40 mmHg. Deep hypothermia circulatory arrest total time was 40 minutes and cerebral perfusion time was 38 minutes. After termination of bypass, veno-venous muff was done. It is a unique muff style, not veno-arterial. Urine output 80 ml. Total bypass time was 155 minutes. Total cross-limb time was 95 minutes. And the post-surgical scans was normal. Patient was discharged on 10th post-operative day. I would like to conclude this topic on this note that meticulous perfusion management integrating precise blood flow regulation, deep hypothermia circulatory arrest, selective antegrade cerebral perfusion, controlled hemodilution, and patient-tailored ultrafiltration is vital for optimal neurological and systemic outcomes in infant aortic arch reconstruction. Please remember one thing, being a perfusionist, our perfusion skills are not just a technique. It's a lifeline for every patient. Thank you. If any question, please.